2, 1. We are live now.
Can you see my screen?
Yes, sir. We can see.
No, my screen, full screen?
Yes, full screen.
Yes,
We can see, sir.
be able to see, sir.
It gives me great pleasure as the chairperson for the IOA Knee Preservation Subcommittee 2023 for the second webinar. And we are privileged to have Dr. Mittal for his one topic, one speaker talk on STO, its utility and relevance in clinical scenario.
Dr. Rastogi, you are not audible anymore, sir.
Sir, go down on the arrow on the left corner if you want to go. Yes, yeah. Or just press the sir. Yes, yeah.
But I'm not
Arrow
seeing.
here. Arrow on
Yes,
the
now
left
you are
corner.
audible, sir. Yes.
Forward this one, sir. Yes, sir.
And for this, we are happy to have our President-elect, Dr. Chadha, and Vice President, Dr. Anup Agrawal. Last time, as we discussed, we have a huge problem at our hand with more than 46 million people who suffer from knee pain, and they have need to sit on the floor as cross-legged in a squat for activity of daily living and socio-cultural needs. We are not very affluent country. We are 45th in the 94th position in healthcare index. And as we discussed, there are 3 domains of learning, and they are knowledge and attitude. And by organizing these webinars around the year, we have committed ourselves to provide all the orthopedic surgeons across the country with knowledge, which will help them change their attitude for knee conservation. And then in the last face-to-face meeting as pre-conference workshop on 13th December at Lucknow, we'll have a workshop which will be for planning live and for sawbone exercise. So objective of the treatment for a knee osteoarthritis is to conserve the knee for life. And for this, the role of lifestyle modification, weight control, and exercise was amply stressed about by our past president, Dr. Sen. And then we discussed about the success story of STO. And we must remember all the time that TKR is the internal amputation of knee. And this treatment is only good for the last 10 years of one's life. And today's objective of the webinar is STO, its utility and relevance in current scenario, so that we can answer all questions, how useful it is, where to do it, how to plan for it, and proceed with it. And for this, we have Dr. Ravi Mittal, whose main area of interest is knee preservation, and he comes from the premier institute of the country, All India Institute of Medical Sciences. Then we'll have a panel discussion and question answer session in which we have Dr. Milind Chaudhary, who is director of the Lizaro Technique at Ola. He has keen interest in conservation and he has mastered the art of TCVO. Then we have Dinesh Thakkar from Ahmedabad. He is also joint secretary of IOA, and he will also be panelists, and we have Dr. Ajit Saigal, who is also member of IOA Knee Preservation Committee, and incidentally, he is also Secretary General of SARC Orthopaedic Association. And this is me. And now we have a word of wisdom from our President-elect, Dr. Ram Chadha.
Good evening, everybody. On behalf of the Indian Orthopaedic Association and on behalf of my dear colleague, Dr. Atul Srivastava, President IOA, I welcome you all for this, the second of the webinars of the sub-speciality of knee as far as preservation is concerned. I have with me Dr. Anup Agrawal, our Honorable Vice President, and Dr. Dinesh Thakkar, our Joint Secretary representing the IOA. I welcome each one of you, specifically Dr. Ravi Mittal, who has given us the time and is going to share his knowledge with us. Dr. Sanjai Rastogi, Dr. Milind Chaudhary, my dear friend from Akola, Dr. Dinesh Thakkar, I have already welcomed. And if Mangal joins us, it will be a pleasure to have Mangal as well. Saigal Saab, I believe, will be joining us shortly. I go back to the training days when I worked at Sion Hospital and Milind worked in a close-by hospital where Dr. K.T. Dholakia used to do a left-handed transverse incision below the knee. And he used to do a closed wedge osteotomy. And it used to be a matter of minutes. He used to go out, have a cup of coffee, come back and plaster the knee himself. And for us, that was high tibial osteotomy done by the best in the best circumstances. I moved to Chennai in 1994, end of 1994. And lo and behold, I was exposed to a medial open wedge. I said, this is interesting. Iliac crest used to be opened, 3 large wedges of bone used to be taken out, and the laminar spreader, which we used in the spine, was taken away from us that day and opened up on the medial side, and these 3 large wedges of iliac crest were put in there. Well, all these patients seemed to do well, till finally the trade got in, and then everybody got into putting more and more resurfacing. I was taught that use the word resurfacing, don't call it total knee replacement. And then it has evolved to a stage now where we have a balanced opinion. We have people, even the leading surgeons themselves, who've gone for neither the knee replacement nor the closed or open wedge, but have got rings to get themselves corrected gradually. So somewhere in between is the correct answer. To help us today, we have this very elite, eloquent, enabled group of knowledgeable teachers who's going to share their opinion with us. And I'm sure it will be something where each one of us would learn to move forward and put in the TKR as the last and not the first resort. Thank you for having this meeting. Thank you for inviting us. And back to you, Dr. Rastogi.
Thank you, Dr. Chadha. Now, I request Dr. Anup to quickly say a word of blessings as the Vice President.
Thank you, Dr. Sanjai Rastogi, sir, for having me here. It's a pleasure to meet you all, and I can say that Dr. Sanjai Rastogi is one of the pioneers who is holding high about the HTO, and we have Dr. Milind Chaudhary, Dr. Ravi, Dr. Ram Chadha, sir, has already told you about that where we are lying, and this art we all must learn. And today's the time where Dr. Ravi Mittal is going to put a light on this particular aspect. So I'll not come in between the academics and the delegates. Back to you, sir.
Thank you very much, Dr. Anup. Now I request Dr. Ravi Mittal to take us the present status of HTO.
Can I share the slide?
Yes, sir.
Can you see my full screen?
No, now it is clear.
Yeah.
And your voice is clear.
Yeah. First of all, I have to thank all the officials from the Indian Orthopaedic Association and Dr. Sanjai Rastogi for giving me this opportunity. I also thank my co-panelists who will be helping me in this presentation. And I thank all the audience and the doctors who have joined us for this webinar. I'll begin on a philosophical note. In the Journal of Arthroscopy, in the issue of August 2022, an editorial was published which was entitled Stop Overtreatment, Overdiagnosis, and Medicalization of Normal to Improve Healthcare Outcomes. And the editor talked about a book called Hypocrisy. And the hypocrisy word is derived from the word Hippocrates, who is the father of the modern medicine, and the word hypocrisy. And in this editorial, the editor suggested that doctors who base their practices on what is commonly accepted, on what they perceive to be effective, are often unknowingly wrong. That means what they believe at times is wrong, and they base all their practices on that. And the word was unknowingly wrong. They are not deliberately wrong, but unknowingly wrong. So why they are wrong? Because they are all bombarded with some false evidence. This false evidence comes in form of print media, electronic media, WhatsApp, and also emails. And this false evidence is bombarded so much from all the sides that it starts appearing real. And at times, this false evidence is also propagated from senior colleagues in various conferences or seminars or webinars. But the problem is that it is false, and one has to be beware of these false evidence. To give you an example, now I'm getting all these advertisements on my WhatsApp, on my emails by a company, and in the garb of patient information, patient awareness, knee replacement is being advertised for the treatment of large joint disease. Now, the only treatment that they are advocating is joint replacement, nothing else. So one has to be aware of these kind of advertisements and knowledge that is being propagated by various sources. Now, knee replacement is very popular. It is widely and aggressively marketed by the companies. Patients come and demand this procedure, and surgeons go out and sell this procedure. So when I talk about HTO, it is like swimming against the tide. But I'll try my best to convince the audience about the utility of HTO in the current scenario. Now, when we look at the osteoarthritis of the knee, it usually starts from the medial compartment, and later it progresses to the lateral or patellofemoral or both the compartments. But the question is, why does it start in the medial compartment of the knee, for which we are advocating high tibial osteotomy? Now, there was a study published by Dr. Arun Mulaji from Bombay, where they studied a normal population, and they found that there is inherent virus in the Indian population, and this inherent virus is in about 35% of the population, and 50% had tibia vera. Tibia vera means that the medial proximal tibial angle is less than 87 degrees. There are various methods to identify tibia vera. Medial proximal tibial angle is one of them. The other parameter is tibial bone varus angle. This is an angle between the mechanical axis and line perpendicular to the epiphyseal line. If this angle is more than 5 degrees, this is tibia vera, or a varus in the proximal metaphysis of tibia bone. So this is our normal population. Without osteoarthritis, they have this varus deformity. So that is why when the weight bearing occurs, the more of weight is there passed through the medial compartment, and that is why it wears out earlier than the lateral, and that is why we have the medial osteoarthritis commoner than the lateral osteoarthritis. Now, for the treatment of osteoarthritis of knee, we have some non-pharmacological interventions, pharmacological interventions, and surgical interventions. And a variety of all the three things are available to us. And the guidelines for knee osteoarthritis treatment start from self-management, medical therapy, and lastly, the surgical options. If you look at the surgical options, arthroscopy is number one, but it is hardly used for osteoarthritis today. The second option is osteotomy, and the last is arthroplasty, or the knee replacement. So how do we select a surgical procedure for knee osteoarthritis? If you look at the picture on the left, medial compartment shows osteoarthritis, whereas the lateral is relatively normal. So this patient would be suitable for high tibial osteotomy. If you look at the picture on the right, we have joint space reduction in both the lateral and the medial compartment. This patient would not be suitable for high tibial osteotomy, and on the contrary, it will be suitable for knee replacement or TKR. But the problem is, in our country, majority of the knee replacements are being done for medial compartment osteoarthritis. And what if TKR is done in a case which is suitable for HTO? My submission is that it will amount to overkill. Now, since this is an early osteoarthritis, the age of the patient would be less than 60, and later on he will require revision. The parameters which nobody talks is the lifestyle alteration and physical restriction that is imposed by TKR on these patients. Now, this paper in the Journal of Osteoarthritis and Cartilage shows what is the distribution of osteoarthritis in various compartments of the knee. So if you look at the single compartment constitutes around 50%. And the combination of medial compartment, isolated medial compartment is 27. The combination of patellofemoral and medial compartment is around 50%. So that's the distribution of disease in the population. But if you look at the usage of TKR and UKR, that is not commensurate with the distribution of disease in various compartments of the knee. The usage of the TKR and UKR is much higher than the distribution of the disease in different compartments. That's the reality. And what is not told about the knee replacement when it is given to the patient, that there is a limited longevity of the prosthesis, imposes many physical restrictions and altered lifestyle for the patient. Ideally, a TKR implant should outlive the patient. And this is possible if TKR is done after the age of 60 to 65 years. But if it is done earlier than that, revision surgery is required. It also imposes physical restriction. Patient cannot squat, cannot sit cross-legged. Running and sports are advised to be not done by the patient. It imposes altered lifestyle. Patient cannot sit cross-legged for puja or sajda for namaz, which is an important thing in our society. Patient cannot sit on floor for various social gatherings. Professions like gardening and farming have to abandon. And a person who is living in the city, he has to run after a bus or a train. Now, that is also not possible after total knee replacement. So he has to change his lifestyle, which is not acceptable to many people. So who is best suited for a TKR? He is an elderly person, more than 60 to 65 years of age. And for him or her, all the non-operative measures have failed, and there is bi-compartment or tri-compartment disease in the knee, which is indicating that there is a late stage of the disease. But if the age of the patient is less than 60 to 65 years, only medial compartment is affected and non-operative measures have failed, this patient is more suited for high tibial osteotomy. High tibial osteotomy provides good pain relief. It imposes no restriction on activities and no change in the lifestyle. It is much cheaper than the TKR, although the cost difference is not much after the capping of the cost of TKR by the government of India. But however, in the past, the difference was much larger. And it is more suited for Indian conditions where people like to squat, sit cross-legged, do puja, and do namaz. The aim of high tibial osteotomy is to provide pain relief, decrease the rate of progression of disease. You cannot stop the progression altogether, but you decrease the rate of progression. It promotes osteochondral repair in the medial compartment, and it delays the need for replacement of the knee joint. And this delay can be there for the whole lifetime of the patient. Now, why are we talking about HTO? Is it a new procedure? No, it is a very old procedure. It is much older than TKR. If you look at the history of HTO, osteotomies were done for a very long time, but the modern HTO was started by Jackson and Waugh in 1961. It was later popularized by Coventry, who was working in Mayo Clinic, and he was advocating closed wedge high tibial osteotomy. At that time, the closed wedge high tibial osteotomy was done by visual judgment. Proximal tibia was cut, a wedge was removed. The wedge was, the distal fragment was moved laterally to close the wedge, and a plaster was given. Minimal implants were used, either K-wires or some tension wiring were done. And later, if there was no implant, the wedging of plaster was also done later in the follow-up to do some minor correction in the angulation of the limb. But the results are variable because there was varying degree of correction because it was done by just visual judgment. So the outcome was very variable. People had doubts about its efficacy. It was not very predictable at that time. And when TKR and UKR came, they were sort of the last nails in the coffin of the HTO, and the HTO became less popular. But the revival of HTO was done by Pudu, who was working in Rome. He advised open wedge osteotomy, and he used an angle stable implant. And there were many other contributors to the revival of HTO. But the important thing was people started emphasizing on the accuracy in the correction of alignment of the limb. And they found that the correction was the key element in the success of the HTO. If you look at the history of HTO, in the early 1960s, Jackson and Waugh introduced it. Coventry popularized it. He even made a Coventry staple. In 65, Muller started using a T-plate for the osteotomy. Then Fujisawa described the Fujisawa point, describing what should be the weight-bearing line, what point should it pass through. Dugdale talked about some calculations, preoperative calculations. Magyar talked about hemicaliotesis, that means slow correction using external fixators. And then Pudu in Rome described open wedge osteotomy using a locking plate or an internal fixator. And this procedure was later modified in Germany by Stabli and Laumenhofer. And what we have today is the modern HTO, open wedge osteotomy by Stabli and Laumenhofer. So if you look at the historical osteotomy, which is before 1940, the technique was rudimentary and variable, and there were complications like loss of correction, infection, stiffness, because all these were put in plaster. Then the early modern years from 1940 to 2000 year, people started developing secure fixation technique, either using internal fixator or external fixator. They identified ideal corrective angle for the longevity of the procedure, and they had idea about pre-operative planning. And even in this period, the overall survival rate of HTO was 90% 5 years, 77 to 78% at 10 years, and 71 at 15 years. So even in this time, HTO had good outcome. And then now, after year 2000, we have a resurgence of open wedge HTO, and we had fixed angular stable implants. Different kind of plates are available today, and the procedure which was done using external fixator, either ring fixator or tubular fixators, now the patient did not have the hassles of some plates, rods and wires going through his knee externally. Rehabilitation was started earlier to reduce stiffness. Even computer navigation techniques came, and the HTO procedure was done for various other disorders besides osteoarthritis in the medial compartment, like articular cartilage problem and meniscus problem. So that's the history of HTO in summary. So we know now that HTO is not a new procedure, but it has evolved. It has been made more accurate and predictable. So is today HTO an abandoned procedure? My answer is it's not an abandoned procedure. On the contrary, the surgeons and the physicians have taken a Walmart-like approach. So what is Walmart-like approach? Now, if you go to a supermarket, the items or the commodity which is to be sold early by the supermarket is exhibited in the passageway. It is exhibited at the eye level of a person, and rest of the things are in the far corners. They are either above the eye level or below the eye level. So the surgeons and the physicians have advocated TKR and UKR very aggressively, and they have stopped talking about HTO. So they are suggesting HTO only when the patient demands it. There are only a few people who are advocating on their own. Why are we talking about today? Because more talk means more action. And in this webinar, we would like to re-emphasize that TKR is not suitable for everybody. HTO is a very good option in the medial osteoarthritis of knee. And today, when we have the new techniques of HTO with the modern implants, the results are very good and predictable. So when we do HTO, we have to do some analysis and planning. And the issues which concern a surgeon is there a deformity? In which bone is the deformity? In which part of the bone is the deformity? And why to correct it? And where to perform the osteotomy? What is the prerequisites and contraindication, and how to do it, and how much the correction? So we'll discuss each and every point in detail. So to decide about a deformity, we should have an objective parameter. We should be able to quantify the deformity, and it should be reproducible and very objective. It's not subjective. For that, we use the parameter of mechanical axis and anatomical axis. The mechanical axis is a line which is passing through the center of the hip to the center of the ankle joint, and in a normal knee, it passes to the center of the knee. This is the mechanical axis, whereas the anatomical axis of a femur is a mid-diaphyseal line in the femur and the mid-diaphyseal line in the tibia. In the tibia, the mechanical axis and the anatomical axis are same, whereas it is different in the femur. Then we talk about mechanical axis deviation. Mechanical axis deviation is the perpendicular distance from the mechanical axis to the center of the knee joint. If we draw a mechanical axis, normally it should pass through the center, but if it passes medial to the center of the knee joint, it indicates a varus, and if it is lateral, it indicates a valgus. And since the normal population has also some varus, the varus which is considered pathological is when the medial axis deviation is more than 15 millimeters on the medial side. That means the weight-bearing line passes more than 15 millimeters from the center of the knee joint. That's considered to be a pathological varus. Otherwise, it's a physiological varus. So we need to have a weight-bearing X-ray from hip to ankle to determine whether this patient has got a varus or not. And how to take this X-ray? The patient has to be standing, bearing equal weight on both the limbs. The patella should be facing anteriorly, and that requires some internal rotation of the limb. And the X-ray has to be taken on a single cassette. It is not pasting of the different X-rays, 3 X-rays from top to bottom, and you make a big one. It is single X-ray. That's how you take this X-ray. Then we have to decide in which bone is the deformity. Conventionally, it is a tibia when there is a varus deformity, and it is femur when there is a valgus deformity. But again, we need to be very objective, and scientifically, we have to use mechanical axis to be very accurate and scientific about it. Now, besides the mechanical axis, we also draw a line which is parallel to the tibial condyle and the femoral condyles of the knee joint. Now, if the angle which is formed by the mechanical axis and the line tangential to the femoral condyle, which is the angle which is formed by the these two lines, is mechanical lateral distal femoral angle. If it is more than 90 degrees, that means the varus is in the femur. And similarly, you have an angle between the mechanical axis of the tibia and a line which is tangential to the tibial condyles. When this angle is less than 85 degrees, which is the medial proximal tibial angle is less than 85, the varus is in tibia. And this is called the malalignment test. That determines what is the site of the bone where which is the offending bone in the varus deformity. And another situation could be a ligament laxity. We draw the lines tangential to the femoral condyle and the tibial condyle. Normally, this angle is called the joint line convergence angle, and the value is less than 2 degrees. If it is opening on the lateral side and it's more than 2 degrees, that means the cause is the ligament laxity on the lateral side. So in the varus deformity, if we have a medial proximal tibial angle less than 85 degree, that means the deformity lies in tibia. If the mechanical lateral distal femoral angle is more than 90 degrees, that means the deformity lies in the femur. If both the angles are abnormal, that means the deformity is contributed by both tibia and femur. To give you an example, we have a varus deformity on the right lower limb of this patient. Now we have to decide where is the deformity, either in the tibia or in the femur. So we have to draw some lines as shown in this figure. We draw the mechanical axis, and the medial axis deviation is pathological. That means this is the varus deformity. Then we draw the mechanical axis of femur and tibia, and lines parallel to the tangential to the condyles of the tibia and femur. And we find that the medial proximal tibial angle is normal, whereas the mechanical lateral distal femoral angle is more than 90 degrees. So the problem lies in the femur and not in the tibia, even though this is a varus deformity. So that gives an objective criteria to determine the offending bone in a varus deformity. Then the question arises, which part of the bone? Conventionally, it is distal femur for valgus and proximal tibia for a varus. But again, we have to be objective. We can use either anatomical or mechanical axis. It is much easier to use anatomical axis to determine which part of the bone is offending. We draw anatomical axis for each segment of the bone, and we draw a normal proximal tibial angle and a normal lateral distal tibial angle and find the cora. So these are the various situations where we have a varus in the tibia. When we draw a anatomical axis, we find the deformity lies in the diaphysis. This is the cora. Cora is the center of rotation of angulation. This is the usual situation in medial osteoarthritis. We find that the deformity lies in the proximal tibia. This is a situation where the varus is because of the deformity in the lower tibia. And this is a situation where the deformity lies in the diaphysis and also in the lower tibia. So we have to know what is the site of the deformity. It is not always proximal tibia. Then the question arises, why should we correct this deformity? Now, this is an X-ray of a patient who had vitamin D resistant rickets and a varus deformity on both the lower limbs. This is a young girl who has a varus deformity on the left side because of some childhood injuries. This is a middle-aged person with medial compartment osteoarthritis. So in these two cases, the reason is cosmesis. Before the onset of osteoarthritis, we have to correct the deformity. And in this, the reason is pain after the onset of osteoarthritis. So there could be two different reasons for doing a osteotomy. In an age group before the onset of osteoarthritis, the reason is cosmesis and also a preventive. That means to prevent the onset of osteoarthritis later in the lifetime of this patient. Then the question is where to perform the osteotomy. The answer is it is same as we do in the Lizro, at or as close to Cora as possible. Now, if you don't do at a site which is at the Cora or very close to the Cora, we create another deformity. Now, for a medial compartment osteoarthritis, the Cora is at or very close to the joint line. So we do a osteotomy in the proximal metaphysis. The additional or the fringe benefits of this is that we have better healing in the cancellous bone. And if you're doing a closed wedge osteotomy, the patellar tendon provides compression and a better healing for this osteotomy. We have different types of osteotomies: a closed wedge osteotomy, which is a lateral based closed wedge, an open osteotomy, which is a medial based open wedge, or a dome osteotomy. The open wedge osteotomy can be done with a graft or without a graft. We can also have a hemi-closed and a hemi-open osteotomy, and we can do this osteotomy using internal fixator or external fixators. But the bottom line is all these osteotomies aim to achieve the same mechanical access after correction. There is no difference in that. Now, how to select open versus closed wedge osteotomy? Broadly, it's the surgeon's choice. And both the osteotomies give equally good results. It's basically a surgeon's choice. If you talk about a closed wedge osteotomy, it was popularized by Coventry, who worked in Mayo Clinic. This is an osteotomy done through the cancellous bone to the Cora. Now, in the medial compartment, the Cora lies somewhere here, and you are doing a very close. You can't do osteotomy at the joint line, so you are doing a osteotomy very close to the Cora. There have been many modifications of the procedure, which was described by Coventry. People started using implants. There have been different types of osteotomies for the fibula, but it is very logical that you correct a bony varus. You can also tighten the LCL by reattachment when working on the lateral side of the knee. We remove a lateral based wedge. The gap is closed, and traditionally minimal or no implants are used and a POP cast is given. The issues with Coventry procedure is that we have a proximal shift of the tibial tuberosity, producing a pseudo patellar alta, but that's not a problem for the patient in a majority of the cases. The issue is a truncation of the proximal tibia. Truncation is something like this. Now, this issue does not concern the patient or the surgeon who does the HTO, but this concerns a person who would be doing a TKR later on. They find it difficult to put the implants in this type of tibia later on. Another issue with the closed wedge osteotomy is that you are stuck with the wedge that you have removed. You cannot change the size of the wedge once you have removed this wedge. So there are chances of undercorrection and overcorrection with this closed wedge osteotomy. Another issue is that you require a fibula osteotomy either in the diaphysis or very proximal and near the head. And when you are using just a POP and not any internal implant, the knee mobilization is difficult. It is delayed. But a closed wedge osteotomy is mandatory when you have a pre-existing patella baha, or there is a need for lateral orthotomy for some reason, or a posterior slope has to be decreased. The tibial slope has to be decreased. It may be there when you have an ACL injury and you need to decrease the slope, then you have to do a closed wedge osteotomy, and just by decreasing the slope, you can take care of the medial compartment osteoarthritis and the ACL injury at the same time. You may not need to reconstruct the ACL in this situation with a closed wedge osteotomy. Now, if you look at the failure, the cause of failure of HTO, it is mainly the loss of valgus correction because no implants were being used. And when you have a large correction, there is invariably a fracture of the opposite cortex. So this correction has to be maintained till the time the osteotomy unites. And this is the crux in the HTO. So you need to have a very stable fixation. You're doing the HTO. Otherwise, there are chances of loss of valgus correction. Now, open wedge osteotomy was introduced in 1987. It has better adjustability. You can titrate the opening of the wedge. You have no truncation of proximal tibia. There is no problem of patella alta, and it can be done using internal fixator or a locking plate, or using external fixator, ring fixator, or tubular fixator. So the problems of closed wedge osteotomy are mostly overcome by open wedge. Since you can titrate the opening of the open wedge, accurate correction is possible. It is easier, it is faster because you are cutting tibia at only one point. You're not cutting the fibula. No truncation of the proximal tibia is there. And since you are using some implants, either internal or external, early mobilization is possible. Now, why this open wedge osteotomy is possible now? The answer is that now you have a pre-molded angle stable implants. Various types of angle stable implants are available, which are pre-molded. You don't have to bend them. And they provide a very good initial stability. And this stability is continued till the osteotomy unites. So you don't have any loss of correction with these implants. And that is why you have accurate correction of the deformity and more predictable results with these implants. How does HTO work? The answer is it has both a mechanical effect and a biological effect. You shift the mechanical axis from the medial to the lateral compartment. We unload the medial compartment, and so the pain is relieved on the medial side. The biological effect is you decompress the medullary hypertension. Now, when I say decompress the medullary hypertension, it sounds very imaginative or not real. But I'll give an example. When we do a core decompression in avascular necrosis, the main aim of core decompression is relief of pain. And the relief of pain is by the decreasing the hypertension, the venous hypertension in the bone. That's one of the reasons of pain relief, the main reason for pain relief in AVN by core decompression. To substantiate this evidence, I present you this case report, which was published in Journal of Arthroscopy a long time back in the year 2001. Now, there were surgeons from Cuba who were not doing a formal osteotomy for the osteoarthritis of knee, they were just using saw to just cut the bone partially in the tibia, in the femur, and even in the patella, wherever the site of osteoarthritis was there. And they found even just by cutting the bone partially, they could achieve pain relief. And the mechanism was relief of medullary hypertension. The third benefit of HTO is that the medial meniscus extrusion, which occurs in osteoarthritis, that is relieved. That means the medial meniscus, normally the outer border of medial meniscus is in line with the tibial condyle and the femoral condyle on the medial side. This is extrusion. Now this moves back when you do a valgus osteotomy or high tibial osteotomy in medial compartment osteoarthritis. So when this meniscus moves in, you have some relief of pain. That's the third mechanism. So what are the prerequisites for HTO or indication or a patient selection? That the patient's age should be preferably less than 60, but 60 is not a sacrosanct cut-off figure. The varus should be less than 15. It should be a pure medial osteoarthritis with a metaphyseal varus. The contraindications is a bicompartment or a tricompartment osteoarthritis, or an isolated lateral compartment osteoarthritis, varus more than 15, flexion contracture more than 10 degrees, range of motion less than 90 degrees, bone loss either on femur or tibia or both, that's a contraindication, and a subluxation more than 1 centimeter. If you look at the ESACOS guideline, ESACOS is a society for arthroscopy and knee surgery. An ideal patient for HTO would be a patient with isolated medial joint line pain, age 40 to 60, BMI less than 30, high demand person, but no running or jumping, minor alignment less than 15, metaphyseal varus, full range of motion, a normal lateral and patellofemoral component, no cupula, that means the bone loss, normal ligament balance, non-smoker, and some level of pain tolerance. But the same guidelines said that the HTO can also be done if you have a flexion contracture less than 15, there's a previous infection in the knee joint, the patient may be less than 40 or more than 60 to 70. So up to 70, you can easily do HTO. You can also do HTO when you have either a ACL or PLC or PCL insufficiency. You can incorporate change of slope in the HTO and do it to counterbalance the ligament deficiency also. You can also do it in moderate patellofemoral arthritis and in a person who wishes to continue all sports. But it is contraindicated in bicompartment disease, a flexion contracture more than 25, obese patient, and meniscectomy in the compartment which is to be loaded. That means if you have a lateral meniscectomy done for a patient, you can't do HTO. So what does HTO do? It shifts the mechanical axis from medial to lateral. How much to shift? To a point which is around 62% of the tibial width. And the accuracy determines the clinical outcome. It is the accuracy of the initial correction and maintenance of this correction which determines the clinical outcome. So the goals for HTO and varus deformity is shift the medial weight-bearing axis from medial to lateral to achieve 3 to 5 degrees of mechanical valgus, 8 to 10 degrees of anatomical valgus, so that the weight-bearing line passes through 60 to 66% of the tibial width, which is the Fujisawa point. So we are opening the medial wedge with the laminar spreader. You can titrate the opening of it, and you can change the opening of the wedge till the weight-bearing line or the mechanical axis from the center of the hip to the center of the ankle joint passes through the Fujisawa point. So this is a pre-operative X-ray on the left side. the mechanical axis passes outside the knee joint on the medial side, and after the osteotomy, it passes to the Fujisawa point. In either case, the mechanical axis passes outside the knee joint and after the osteotomy through the Fujisawa point. Now, how much to open up during the surgery? Now, calculation of the wedge size is important for a closing wedge osteotomy. It is less important when you're doing a opening wedge osteotomy because you can always fine tune your opening of the wedge under the image intensifier. So the methods which are described are Coventry method, the noise method, and the Miniasi method. 3 methods are there. Now in the Coventry method, it is based on the anatomical axis of the lower limb. The angle of the wedge is equal to the planned anatomical axis minus the preoperative anatomical axis. If suppose the patient has a preoperative 4 degree of varus and you want to achieve 8 degree of valgus, it will be 8 minus 4, but this 4 will be minus 4 because you're taking valgus as positive and varus as negative. So your angle should be 12 degrees after the wedge should have an angle of 12 degrees. But when you're using this method, you should have the angle guide intraoperatively on the table to measure the angle of the wedge. Not everybody has this angle guide. The other method is that you calculate the size of the base of the wedge, which is side B, when you're in the Coventry method. So if this is the angle A on the medial side, the tangent of A is base upper hypotenuse. So the base would be the tangent of the angle into the H height, and this is the width of the tibial condyle. So that's another method that you put one wire here, and at a measured or predetermined distance, you put another wire and you remove this pre-calculated wedge. For this method, you don't need an angle guide. The noise method is based on mechanical axis passing through the Fujisawa point. You draw the lines on the whole limb X-ray, center of the hip to the Fujisawa point to the center of the angle, and whatever angle is formed by these two lines, that determines the angle of the osteotomy. It can also be done on paper tracing. You cut the template and rotate it till the overlap of the paper determines the angle, and this angle or this angle determines the angle which you have to achieve intraoperatively. Now this is based through the paper tracing. The other popular method is a Miniasi method. It is based on mechanical axis passing through the Fujisawa point. So if you have this whole limb X-ray, you pass a line from the center of the hip to the Fujisawa point and extend it at a point which is at the same distance, same level at the center of the angle. From the site of the proposed cora, you draw a line to the center of the ankle joint and center from this point to the proposed virtual site. And the angle which is formed will determine the angle which you have to remove from the lateral side. This is for the closed wedge method. For the open wedge, again, you have to do the same thing. This is the line passing through the center of the hip to the Fujisawa point, and you extend it down at the same level at the virtual A. This is the cora on the, when you're doing an open wedge, the cora comes on the lateral side. From the cora, you draw a line to the center of the ankle, center of the virtual A, and this angle is the angle that you have to achieve at the open wedge osteotomy. So again, this is the preoperative X-ray and the postoperative, and the line passes to the Fujisawa point postoperatively. Now, how do we do? What are the steps for medial open wedge high tibial osteotomy? Now, there could be many methods of doing it, approaching it, cutting the bone, but I'll tell you what I do. So this is the X-ray with the medial compartment osteoarthritis. And these are the lines that we have drawn. Now, if you draw a mechanical axis, center of the hip to the center of the ankle, it is outside the knee joint. So this is definitely a varus deformity with a loss in the medial compartment joint space. You draw a mechanical axis of the hip or the femur and the tibia, and you draw a line parallel to the joint, tangent to the femoral condyles and the tangent to the tibial condyles. And you find that the medial proximal tibial angle is abnormally low, whereas the lateral distal femoral angle is normal. So this patient is suitable for HTO. Now, various incisions have been described. Some people use a small straight incision, small oblique incision, small horizontal incision. Now, this line indicates the joint line, and I use a L-shaped incision, and we raise a full thickness skin flap that includes the subcutaneous fat, and we leave the periosteum and the pes on the tibia. We cut the soft tissues at a point which is parallel, in a line which is parallel to the proximal margin of pes and serenas. And we cut the MCL also transversely. And we put a Hohmann's retractor there, and we erase the popliteus muscle from the back of the tibia so that the neurovascular bundle is very well protected by the intervening popliteus muscle when we are cutting the bone. We make a proximal cut here and and back underneath. We also take a small incision distally so that the pes from this is released, because when you're opening the wedge, the pes become very tight and you have to release the attachment of the pes from the proximal tibia. We pass a wire from the medial side to the lateral side, and this is the site where the tibia changes the angle. It corresponds to the proximal end of the fibula head. You pass a wire there, and at this position you can see two lines on the medial tibial condyle. So you just flex the knee by keeping a roll under the knee joint, so that on image you see just a one sharp line of the medial tibial condyle. You pass another wire which is parallel to this, so that on image you see only one wire as an image. So you see two wires here, one wire here, and this is the image with two wires, and this is the one line of the medial tibial condyle. That determines the slope of the proximal tibia, the posterior slope. Then you plan a osteotomy which is like this. Now when you're going the osteotomy like this, remember you have to protect the patellar tendon, and at the same time you don't have to go inside the knee joint. So these are the two wires. This is my Hohmann at the, sorry, something happened. This is not from me. This is not from me. Okay, are we at the same slide? So you don't have to go inside the knee joint. At the same time, you have to protect the patellar tendon. And for this, we use saw and osteotomes, but
Dr. Mittal, you are not audible. Dr. Mittal.
yeah, okay.
Okay.
Okay. Is it okay now?
Yes, yes.
So you have to use a saw blade, which is not from the TKR set. You have to use a saw blade, which is much thinner, much smaller in length, much smaller in width, and it's much thinner. And your osteotomes are also much thinner and sharper. Something has happened here. Yeah. Now you use the osteotome and saw to cut along the wires. Now the important precaution is that you don't enter the knee joint with your saw and osteotomes. So you have to ensure that you place your guide wires correctly. The osteotomy is done below the guide wires so that the wires prevent the entry of saw and osteotomes into the knee joint. And your thin and sharp saw blades and osteotomes are used. And you go slowly, don't hammer it vigorously. It will create iatrogenic fractures. To prevent iatrogenic fractures, you have to use small blows with less of force. And after doing this biplanar osteotomy, you put in a laminar spreader and you open your osteotomy. The important precaution is that you have to place the laminar spreader in the posterior part of the medial tibia, not anterior. This is the anterior, this is the posterior. You always place it posterior. You place this posterior so that the slope of the proximal tibia does not change. And the opening of the osteotomy is titrated by taking images, center of the hip, center of the ankle, and then you see the Fujisawa point. If it's passing through that, it's okay. Once you are decided that the opening of the wedge is okay, you can notice that the opening of the wedge is more posterior and less anterior. That should be the normal thing. It should never be more anterior and less posterior or equal anterior and posterior. Otherwise, the slope of the proximal tibia will change. At this time, you can close the soft tissues here. You place your tomofix on the tibia. Fix it provisionally with a drill and see that the lower part in the proximal, the lower hole in the proximal segment and the upper hole in the distal segment, they are on the bone. They are not in the wedge side. You have to ensure that. And you pass the holes in the proximal segment. And after passing in holes, screws in the proximal segment, you put it on the distal segment, and then you check the alignment again after the plate application. At times your view would be like this. This is without valgus stress, because at this time the patient is lying supine. This is not a weight-bearing position. The weight-bearing position or the actual situation when the patient is walking can be simulated by giving a small valgus stress. So if you achieve this, this is good. After putting the plate, you check for slope, you check for screw position, and also you check for screw penetration in the tibiofemoral joint. If your screws are long, it can very easily penetrate the tibiofibular joint because that is not seen in the AP view. You always see that thing in the oblique views. So you have to take those views to ensure that your screws do not penetrate in the tibiofemoral joint. The direction of the screw in the tomofix is from anteromedial to posterolateral. To give an example, this is a 50-year-old lady who is a OBG doctor, has bilateral medial compartment osteoarthritis. Now, this lady was not very convinced about the HTO. So she underwent left HTO as a trial. And she said she will not come back to me if she is not happy with HTO. But eventually she came back for the other side and we did a bilateral HTO for this patient. And this is the alignment we achieved post-op. This is a 45-year-old lady who had limited walking after ipsilateral shaft of femur. You can see some old surgery being done here, and she has loss of joint space here. We did a opening by osteotomy. Some other implant was used by me, and this is the correction after the surgery. This is bilateral medial compartment arthritis in a 52-year-old lady. She was unable to walk even half a kilometer. She had failed medical treatment. Range of motion was 0 to 110. And she wanted a bilateral simultaneous HTO. And we did with a Tomofix bilateral at the same sitting. Now, this was an elderly male, 65-year-old male, national level hockey player, failed conservative treatment, and he wanted to preserve his knee. We did a HTO. Since he was a smoker, we put a TCP wedge for him. And this was the alignment we achieved post-operatively. Besides the knee pain, the additional benefits of HTO is that the gait improves because you have corrected the varus, you have relieved the pain, the gait improves. The spinal alignment also improves because you have corrected the varus, you have corrected even the ankle deformity, your abductors are working in a better situation, your spinal alignment improves. And if there is an ankle osteoarthritis, that also improves because your ankle is now in a better position. Now, there are some frequently asked questions by people and they raise some doubts about HTO. The first is, will it cause a lateral compartment osteoarthritis if you're shifting the weight-bearing axis from medial to lateral? The answer is no. It took 50 years for medial compartment osteoarthritis to develop. So it will take another 50 years for lateral compartment, and by the time the patient would have lived his full life. So the answer is no, but the precaution is your osteotomy should not be overcorrected. It should be accurate osteotomy, then only this condition will hold true. If you overcorrect, it will definitely cause lateral compartment osteoarthritis. Is HTO good for complete cartilage loss on the medial side? Yes, the answer is yes. Multiple authors have shown that if you have a complete bone-on-bone or kissing lesion on the medial side, HTO is good. It works very well. And Koshino has shown very well that the function improves and even the cartilage regenerates on the medial side. These are his intraoperative pictures, pre and post-op. He has shown that the cartilage also regenerates when there is complete cartilage loss on the medial side. The other question is it a stopgap arrangement? Strictly speaking, yes. But this gap is long enough when done accurately, when HTO is done accurately. And it is long enough to avoid TKR later on. Even TKR is not a permanent solution. It also has a lifespan. A lifespan, it lasts usually around 15 years. So the same question which is asked for HTO can also be asked for TKR, but people don't ask for it. People ask only for HTO. Is it backed by long-term studies? Yes. Answer is yes. Koshino has said, shown that there is 97% survival at 7 years, 95 at 10, and 87 at 15 years. Other authors have also shown Glosser 94% at 5 years, 80% at 10 years. Akizuki has shown that 97 at 10 years, 90 at 15 years. Tang has shown around 90% 5 years, 75 at 10 years, and 67 at 15 years. So the results are fairly good by number of authors. So it's not a single person study, multiple authors have shown that. Now, if you look at the overall survival of HTO, it is around 99% at 5 years, 94 at 10 years, and around 85 at 15 years. Now, this was a study published in 2019, not very old study. Does it compromise future TKR? The answer is no. There is no difference between the outcomes of a primary TKR and TKR done after STO, and multiple reports have shown that. On the contrary, it makes TKR easier when the deformity, the varus deformity, is not to be corrected by the surgeon. The question is that knee replacement can be done bilaterally at the same setting. Is it possible for STO? The answer is yes, it can be done, but patients who undergo simultaneous STO have a higher chance of need for blood transfusion, and that holds good true for the knee replacement also. Can STO cause patellofemoral problems? Now, the position of the patella changes whether you do open wedge or a closed wedge, but it never causes a patellofemoral problem. The report in 2021 says that you have a patella infra after open wedge STO, but it does not cause any clinical problem or cartilage problem. Is it suitable in old age? In 2013, it was told that age of the patient does not have to be taken into consideration for the indication of high tibial osteotomy. This is the condition of the knee that has to be taken. In 2017, a study was published which showed that the age did not influence the clinical and the radiological outcome after STO. And the study had two groups, one more than 65 and other less than 65. And the results were same in both the groups. Another study in 2019, which said there was no significant difference in the survival rate of STO between the two groups divided by the age, and the division was less than 64 and more than 65. So the age is not a consideration for TKR. You can easily do up till 70 years of age. Now, this was a question which was asked and it was repeatedly asked: is the benefit of STO unpredictable? Yes, it was unpredictable when it was done by just the visual alignment. But who will benefit or not? That is also unpredictable, people say. But first of all, that's not true. But if you can show that the patient is getting benefit with the valgus unloading brace, this patient would definitely have pain relief with the STO. You can also give a lateral heel wedge to this patient. And if this patient says that he has pain relief in the medial knee pain, then this patient will definitely have pain relief after STO. So you can predict who will benefit and who will not. Other question is, if patellofemoral osteoarthritis is present along with a medial compartment osteoarthritis, can you do STO? Yes, you can do if it is just mild to moderate. Obviously, if it is very severe and the predominant symptom is anterior knee pain, your STO will not benefit the patient. But if the predominant symptom is medial knee pain and on X-ray, it is only mild osteoarthritis in the patellofemoral, you can do STO. Then there are some issues for the STO for the surgeon. What implant to be used? Is biplanar better than the uniplanar? Is it always uniplanar and unifocal? And should it be combined with arthroscopy? Should it be combined with any injections? So let's talk about the implant. Now, you can see two types of plate and one external fixator. So it is at times, first of all, it does not matter what implant you use. You can use anything. The ultimate thing is what mechanical access you achieve after the surgery. And whatever fixation you do, it has to be very stable and stable till the osteotomy heals. It does not matter what implant you use. It can be a surgeon's choice, whatever he's comfortable with. Some people are doing with external fixator, tubular fixator. Some people are doing with circular fixator. Some people are using locking plates. They're equally good. And at times it is determined by patient's factor. So I'll give you some examples when it is determined by patient's factor. Now, if you look at this, the whole medial skin is scarred. It is very difficult or say unsafe to put a plate medially. So we used a tubular fixator, did a HTO and achieved good correction and union. Now, this is a patient of a giant cell tumor, which was operated by curettage and bone grafting, but he developed a varus deformity. And he is a barber by profession. He says that he cannot stand for his profession because of pain. So we did a biopsy from this area. We did not show any recurrence of the tumor, the giant cell tumor. And this was his scanogram, standing scanogram. We did a osteotomy using a tubular fixator because everything was scarred on the medial side, who had undergone a curettage and bone grafting on the medial side. And this is the alignment we achieved after the surgery. And this is after removal of the fixator. Now he has pain relief and he has gone back to his profession and he is doing hair cutting very easily now. Should it be biplanar or uniplanar? Studies have shown that the biplanar osteotomy has more surface area, so it heals faster. And since it's a biplanar, it is more stable. Now, a varus deformity in the knee can be associated with deformities in other sites also. Now, this patient has a varus deformity since childhood. Now, if you see a varus deformity which is starting in the childhood, these are often associated with internal torsional deformity of the tibia also, which is seen in this picture. So you have to correct the rotational deformity and a varus deformity at the same time. You can either do two osteotomies, one for the rotational and one for the varus. But if you do a oblique osteotomy like this and fix it by any means, you can correct both the deformities at the same time. You cannot ignore the rotational deformity when you're doing a varus deformity correction. And this cora is also not in the proximal metaphysis, it is much lower down. This is the X-ray I showed you earlier, vitamin D resistant rickets. Without the presence of osteoarthritis, it's a cosmetic problem. If you can see, you have two cora in the femur and the cora in the tibia is lower down with the rotational component. So we did oblique osteotomy in the tibia lower down and two osteotomies in the femur on this side and one osteotomy in the femur on this side. So you can have a varus deformities with more than one focus and in more than one plane. So identify these before you decide to do anything. This is a post-traumatic deformity with the medial compartment pain. He had a varus and a recurvatum. So you have to correct this also. We did a tibial tuberosity osteotomy and then a high tibial osteotomy to correct the deformity. We opened it on the medial and anterior side. Should it be combined with arthroscopy? It is not mandatory. Arthroscopy can be helpful to ensuring that it's a monocompartment pathology. You can manage the meniscal tears and you can do microfractures. But literature has shown that you don't have any major added advantage of doing arthroscopy with HTO in the presence of medial compartment osteoarthritis. So you can ensure that this is a bone on the medial side, whereas the lateral compartment is normal. You can do microfractures and manage the meniscal tear, but this is not mandatory. Should it be combined with injection, hyaluronic acid or PRP? You may combine, but the science of hyaluronic acid and PRP is still not exact science. We don't know the exact dose, preparation, it is still empirical. We don't know the timing, dosage, and the preparation of PRP. But the bottom line is no major side effects or complication of these injections. You may combine. One major issue is comparing HTO and UKR because the patients who are suitable for HTO are also suitable for UKR most of the time. So if you look at the literature, Journal of Arthroplasty, a systematic review and meta-analysis, it says that there is no difference in the functional results in UKR and HTO. There is no difference in the survival of the two procedures. On the contrary, HTO has better range of motion. Another report from Journal of Arthroplasty, a meta-analysis, it says there is no difference in specific knee scores after the two procedures. There is no difference in complications and rates of revision, and our range of motion is better in HTO. Another report from Journal of Arthroplasty, a meta-analysis, it says that with correct patient selection, both HTO and UKR show effective and reliable results. Another report from Journal of Arthroplasty, it says that there is no difference between UKR and HTO in return to recreational activities and short-term clinical outcomes. Cochrane database says there is no difference in the pain, function, and gait after the two procedures. Another meta-analysis and systematic review, it concluded that they were unable to conclude either method is superior. Another report, Journal of Orthopedic Surgery, there was no difference in the outcome at 12 and 24 months. The HTO has better correction of mechanical access, and HTO is the treatment of choice for younger and active patients. That's what the conclusion of this report. Now, this is a paper which showed the data from Australian and Swedish knee registries. And it talked about UKR in patients less than 65 years of age. It showed that the patient who are less than 65 have a higher rate of revision than the patients of 65 or more than 65. So the conclusion is UKR should not be done in younger patients. It should be done in patients more than 65 years of age. Now, if you look at the closed wedge and the unicompartment, closed wedge HTO and unicompartment knee arthroplasty with similar demographics, it says there is no difference in the long-term survival between the two procedures. The failure in HTO is because of progression of medial compartment osteoarthritis, because you cannot stop the rate of the progress of HTO, and when it becomes severe, the patient has pain, it fails. It's an indication of replacement. Whereas the failure in the UKR is because of the femoral component loosening. If you have a failure of HTO, you do a TKR, you use the usual primary implants and only a tibial stem to bypass the defect in the tibia. Whereas if you have a failure in the UKR and you do a TKR, you have to use a revision components and much thicker polythene. So the treatment of failure of HTO is much easier than the failure of treatment of UKR. Now, this was a surprise to me when I read this report, that the mean time to return of sports so much earlier in HTO, the mean time to return to professional activities were much earlier in HTO, and the number of people who are participating in impact sports were much higher in HTO as compared to UKR. So there is no reason for choosing UKR over HTO. There is no reason. Our colleagues from the arthroplasty group, they said that HTO is not suitable for bone-on-bone lesion and you should do UKR. That was a message propagated by our colleagues from the arthroplasty field. And I started looking for it, and what I found was that the Oxford group said that the UKR should be reserved for bone-on-bone lesion. That means you should do a UKR only for end-stage medial compartment osteoarthritis and not when the cartilage is still preserved. They said that. And this group did not comment about HTO. Whereas our colleagues in India, they interpreted in a wrong way. they said that UKR is good for bone-on-bone lesion and STO is not good for bone-on-bone lesion. So it was a wrong interpretation of facts which was mentioned outside India, and in India it was interpreted in a wrong way. Studies have shown that STO is a good option for osteoarthritis with kissing lesion. Kissing lesion means bone-on-bone lesions. And the two groups that studied was with kissing lesion and without kissing lesion. Another study that STO is comparable to UKR in terms of clinical outcomes in kissing lesions, and STO is a good alternative to UKR for medial compartment osteoarthritis accompanied by kissing lesions. So for me, there is no reason why one should choose UKR over STO. There is no reason. If you compare the two procedures, the varus deformity is corrected in STO, but it remains uncorrected or undercorrected in UKR. You can do STO and correct less than 10 degrees of flexion deformity, whereas you cannot correct any flexion deformity in UKR. You can easily do STO in presence of ACL deficiency, and traditionally you cannot do UKR in presence of ACL deficiency, though reports are coming that you do ACL and UKR. So that's a bigger procedure than simple STO. Activity level is unrestricted in STO, where it becomes restricted in UKR. If STO fails, revision to TKR is easy. You use primary implants and at the most a tibial stem, which is very easy. Whereas if a UKR fails, revision to TKR is difficult. You have to use revision implants and much thicker plastic. Spinal alignment improves in STO and it remains uncorrected in UKR. Ipsilateral ankle osteoarthritis improves in STO and remains unimproved in UKR. Gait improves in STO because of pain relief and varus correction, whereas in UKR the gait improves only because of pain correction, pain relief. So if you count everything, STO scores much over UKR. Now look at the data from UK National Joint Registry, the place where the originated. If you look at this, okay, I'll make it fast. If you look at this registry, they found that the 47% of knee osteoarthritis are eligible for UKR, but the usage is only 5 to 8%. And the failure rate of UKR is 3.2% more than that, 3.2 times that of TKR. Only the high volume centers report equal or better survival of UKR as compared to TKR. And this is a vicious cycle. High failure of UKR is there. And this reason they say is low volume and low proportion of UKR done after total arthroplasty. So the remedy is you increase the usage of UKR. And this leads to lower age threshold of UKR. And these lower threshold, lower age people will do increased activity and they will have increased failure rate of UKR. So that's the vicious cycle of UKR failures. You have other indications for STO also. If you have a malunion with varus or recurvatum, with or without recurvatum, this is a post-traumatic varus, and you can do STO in this, and you can correct the deformity and the pain. You have a varus and recurvatum. You do a medial opening wedge with a more opening anteriorly with a bone graft. You have a post-traumatic varus and recurvatum. This is the X-ray I showed before also. With tibial tuberosity osteotomy, you can correct both the things. Another case with varus and recurvatum, with the STO, you can correct everything. With the previous surgery, this is the case I showed you before. This is a final correction. Now, this is another case of proximal tibia GCT treated by bone grafting, healed very well, but complained of varus and medial knee pain. We did a simple osteotomy, opening wedge on the medial side, correct the deformity. And if you see, this is his function. You cannot find out which knee is operated in this patient. He has a normal gait, a normal looking limb on both the sides. It is only the X-ray which will tell you which limb is operated. So there are many indications for HTO besides this. This is after post-trauma. You can change the slope in the cruciate ligament injury. This is chronic PCL with medial OA. We just did a HTO with more opening of the wedge anteriorly and did not do any PCL reconstruction in this case. So normal slope is around 10. You should not change when you're doing for pure medial OA. If ACL deficient, slope can be decreased by doing a closed wedge osteotomy. If PCL deficient, slope can be increased by doing an open wedge osteotomy. You can do it for cosmetic reasons. I showed you this X-ray before. Growth injury in the childhood, correction achieved by a simple osteotomy. This the patient I have showed you before. And you can also do it after microfracture, mosaicplasty, and meniscus transplant. They say when you unload the medial compartment, cartilage healing is better. The determinants of HTO outcome is age and grade of osteoarthritis. Now, I think these two are related, age and grade. It is the only thing which is in the hand of surgeon is the tibiofemoral angle after the HTO. And this is achieved after careful planning, execution, and weight-bearing axis passing through the Fujisawa point. Literature has shown that if you have a tibia vara, that means more than 5-degree angle, the results are better as compared to the case where the tibia vara is absent. So to conclude, HTO is a rational, logical, and a time-tested technique. It has good long-term results, allows understood activities, but you have to select the patients carefully and follow the technique. It needs precision and it does not burn bridges. The benefit of HTO is due to mechanical and biological reason, and you aim to pass the mechanical axis through the Fujisawa point of the surgery. It should be done at or close to Cora, and all methods of osteotomy and fixation are equally good. And it can be done in many other conditions besides medial compartment osteoarthritis. It preserves the original knee. There is no activity restriction. It is easy to do, needs careful planning and perfect execution. There are many methods of osteotomy and implants, but the basic principles remain the same. Thank you very much.
Thank you, Dr. Mittal. So now we move on to the panel discussion. And we have Dr. Milind Chaudhary, Dr. Thakkar, and Dr. To help us do this. I will ask Dr. Milind to give his opinion on the age for doing a HTO.
Well, firstly, congratulations, Professor Ravi Mittal, for very comprehensive coverage of the topic of HTO. Very relevant, very germane. You've hardly left out anything. It's wonderful talk. Thank you. So coming to the age of HTO, Professor Mittal mentioned that you can do it up to 65, sometimes up to 70. Obviously, we all know that there's this concept of physiological age and chronological age. So the physiological age, Dr. Sanjai Rastogi looks young, much younger than his years. So, similarly, a very young 80-year-old can certainly have a high tibial osteotomy. My friends and colleagues from Japan, of whom I'm extremely fond of, because I was, Dr. Sanjay had the privilege of, escorting Dr. Koshino when he came to Mumbai. He's had close relation with Professor Koshino. And now unfortunately, Professor Koshino is no more. He spoke about patients whom he operated beyond the age of 80 regularly, because we all know that the Japanese have very good octogenarians and nonagenarians and centenarians. And now Professor Teramoto, has told us that he's operated on people who are 90 with a high tibial osteotomy. So judiciously, I think with the same indications, that is the medial compartment osteoarthritis, a desire for good activity levels, the lateral compartment being good and the patient being physically active and physiologically young, the chronological age should be less of an issue.
Thank you. There's one thing which I'd like to say about the role of partial knee replacement. If only cartilage is lost and there is no bony deformity and there are no osteophytes and the patient is above 65 and the surgeon has vast experience, then it becomes an indication for doing a UKR. If the patient is young, he requires high activity level. If there are ligamentous instability, then it is better not to do it partial knee replacement. What's your take on that, Dr. Milind?
So I beg your indulgence in answering this question about UKR and HTO. I think there is enough literature and enough industry support for UKR. The interesting takeaway from the HTO 360 conference we held last November, in which a very prominent professor from Delhi attended. Unfortunately, we missed you and we missed Professor Mittal and Dinesh as well, was that he said that the intra-articular high tibial osteotomy could be considered akin to a UKR. And, so this is the extent of my knowledge about UKR. All I can tell you is I'm a little biased, quite honestly, 32 years into different types of high tibial osteotomy. And I have not opened at all the vast chapter of arthroplasty, whether it's partial or complete. So I feel that high tibial osteotomy, whether it's an intra-articular or other type, can do justice to the patients who are bone on bone with or without osteophytes, who are older and will get a good result. Regardless of the classification that Professor Mittal has very nicely elaborated upon, to give a holistic view to the people who are also doing arthroplasty. But I am a dedicated knee preservation surgeon and I am unable to perform a unicondylar knee, but I'm able to give equally good results with a high tibial osteotomy.
Very well said. Dr. Mittal wants to say something on that.
Sir, factually, I cannot say you're wrong. But I would say a person who is fit for UKR is also fit for HTO.
Yes, agreed.
But all patients who are fit for HTO are not fit for UKR. That's the point.
So all patients are fit for HTO, but all patients are not fit for UKR. And everybody who is fit for UKR is fit for HTO.
Correct.
Am I right? Am I right?
Yes.
That's good, but I think if I give honest opinion, suppose a senior citizen, because I realize after doing numbers of high tibial osteotomy that why it has it could not dominate over the arthroplasty till so many years, because we all four, Dr. Milind and Dr. Rastogi and myself, are trying since 10 to 15 years, I think. First conference I have attended in 2010, I think Dr. Milind has organized. Still, we could not come across the arthroplasty. One of the practical reason in this present era is arthroplasty can give quick results. That's the only attraction for the patients, because they come back to the work within 15 or 20 days or so. While HTO patient will have convincing results after at least 3 months. So that may be the reason why HTO could not overcome the total knee or partial knee replacement.
You have 3 fingers raised.
Yes. So to set the ball, Dr.
पहले आप बोलिए, sir.
Dr. Milind will give his opinion.
So if you have patients coming to you early enough and you do a high tibial osteotomy, with a mild deformity, early stage of the disease, I've seen this. And I've had orthopedic surgeons with mild deformities who came to me and got a HTO, started walking on the second day, and went back home in 48 hours, drove 1100 kilometers to go back home. People are able to squat in 1 month after surgery if all the wedge that you have to open is 4 or 5 or 6 or 7 mm. It's an early stage osteoarthritis. So I wish to add to what you're saying, Dr. Dinesh, that if the patient comes to us at an early stage, their recovery and ability to go back to work is dramatically fast. I've had orthopedic surgeons who attended their OPD and started operating within a few weeks of the surgery. So so if they come early, they're going to get good early results. If they come late, it will take a little while longer.
And I think the way to tri-compartment osteoarthritis is through a uni-compartment arthritis. So everybody will have a medial compartment osteoarthritis, then bi-compartment, then tri-compartment. So why, if we are late in giving that opinion, then there's a problem. So we have to give opinion early. Dr. Mittal was saying something on this.
So when we compare STO and arthroplasty, you cannot compare TKR to STO because TKR is for bi and tri-compartment osteoarthritis. So when you're comparing, you have to compare with UKR.
Yes.
And a similar argument was given by one of our orthopedic colleagues in a conference where I was talking about STO. And that is the reason I came back and looked at the literature and I put a slide. What is the time to return to profession? What is the time to return to sports? And what is the time to return to impact sports? And that everything is less in STO as compared to UKR. I've shown that slide. So, and that slide is not from India. That slide comes from Germany. So and that is from the AO website also.
Yeah. And actually the point is, if we have done a biplanar osteotomy and fixed with a tomofix, then the rehabilitation is functional from day one, like Dr. Milind said.
Yes.
You can make these patients stand, walk as tolerated right from the next day.
So literature also.
I tell them to give the confidence that you are toilet dependent, not dependent on anybody for toilet activities, even on the day 2 when you go home.
Correct.
So
that is correct.
See, the literature also shows that the recovery is faster in STO as compared to UKR. But you can't compare STO.
Actually, the reason why the reason things are not clear is because people keep quoting about the old closed wedge STO results with the open wedge current results.
Correct.
I think that's the biggest hurdle.
Correct.
So we should sort of clarify that there's difference between open wedge and closed wedge, and the open wedge gives much better, quicker, better, faster results.
Right. It's not just the open and the closed wedge. I would say that this is modern HTO, which is how it started. This is modern HTO.
Yes.
Not the
Yes.
not the ancient HTO.
Yes.
That is why I showed the evolution of HTO in my initial slides, how it has evolved and the thought process has evolved in HTO. And the second slide was FEAR, false evidence appearing real.
Absolutely.
And I'm getting advertisements on my WhatsApp and emails regarding joint replacement by companies now. This was never happening before. And
I never believed this, but when I was
with false
going
information.
through it, in US, they used to market this uni compartment directly to the patients. And everybody was doing and this led to poor results. It's well documented.
This is something which happened in COVID, that you propagate something which is not effective and you earn millions out of it. And in the end you say, oh, sorry, evidence is not right. But the thing is already gone now. So a false evidence propagated multiple times through multiple sources starts appearing real to us. It's true for everybody.
I actually have the opportunity to convert a lot of infected total knee replacements into a knee arthrodesis. And if I get the opportunity to see their original X-rays, I see that many of them are young.
Yeah.
They could have very well been treated with a high tibial osteotomy.
Yes.
Yeah. Instead of subject.
I would like to some of your photographs on that to convey that it should not be done early enough.
Yes, that's true.
If you can, because that is very important.
Yeah.
Because now people start doing it 40, 45, 50, which is
Actually, I came across a very interesting article several years ago that the mortality is higher if you perform a total knee arthroplasty below the age of 55. Somehow, you know, this I will dig this article up for you.
Right.
I came across this article in the year about 2008, and I remember it very clearly.
Right.
That all-cause mortality is higher if a total knee replacement is done below the age of 55.
Yes.
And the other thing to remember is that, you know, there is a German insurance, nationwide insurance collated database that up to 33% of the people who get a total knee arthroplasty are unhappy with the results.
Yes.
So it's not a panacea.
Yeah.
For multiple reasons. So, you know, Dr. Dinesh is the one who's at the spearheading this, you know, why HTO is better than TKR. So, you know, all of us will do well to remember these statistics.
So, I think we should close this as we are already a little late, but I would like to let the audience know that as we had decided early, can you see my slide?
Yes, sir. Yes, we can.
Yeah, we had done these two webinars and one face-to-face program. And for audience to know that we'll be doing a webinar on techniques of medial and closed wedge osteotomy in July. In August, we have one topic, one speaker, Dr. Milind will tell us about TCVO. Then we have a face-to-face program in October at Gujarat. Dr. Thakkar is doing it. Then we have a webinar on technique of TCVO and DFO. And then finally, we have a pre-conference workshop on 13th at Lucknow. So this is for everybody to think, and we are always ready to organize programs on demand by lectures. Yes.
Professor Rastogi, I would like to tell you that HTO 360 version 2 is going to be conducted on the 1st, 2nd, and 3rd of December this year again at Akola. We are going to have the physical presence of Professor Tsukasa Teramoto and Nobuyuki Takenaka, who are the leading lights of the intra-articular high tibial osteotomy from Japan. They are going to physically come, and the program will be here soon. And I will apply to the IOA subcommittee to get recognition for this program from the IO. I will be in touch with you. And the first
pleasure will be ours.
The first HTO 360 had 4 demo surgeries in 2 days. We don't discuss UKR, we don't discuss TKR because enough has been done for them. And it will be an exciting, and I really congratulate you for taking this up project for the IOA. You're doing a great job, sir. Thank you.
Thank you so very much.
Thank you.
And then we have Dr. Thakkar doing it in October for us. So we thank Dr. Mittal and all the panelists and all the speakers and OrthoTV, IOATV for their support and support of the association for giving us this platform. Thank you very much.
Thank you all.
Thank
you, Professor Mittal. Thank you, Dinesh. Thank you, Sanjay. Thank you.